Okay, for the sake of everyone's time, we can get started, and then I'm sure people will keep popping on as we go. But thank you all so much for being here. I really appreciate it. I'm so glad we were able to make this happen. So I just wanted to introduce, we have two excellent guests here this morning who will be speaking about the treatment of substance use disorder in our emergency department. Both our guests are from the MGH side of town, but really what they're speaking about can really translate to both sides of town. So like Brigham and MGH with a little bit more of like a focus on MGH specific policies and Bridge Clinic and whatnot. So our first presenter will be Dawn Williamson. So as many of you know, she's an advanced practice nurse for addictions consultation at the MGH emergency department. And she responds to the treatment needs of both individuals and families with addiction and mental health issues in the emergency setting with the ACT team, which she'll be speaking a little bit more about today. After Dawn speaks, we'll give Dinah Applewhite, Dr. Dinah Applewhite, a chance to speak as well. Dinah is the medical director of the MGH Bridge Clinic, which offers patients immediate access to substance use disorder treatment. She's an expert on treating patients in our community who are experiencing homelessness and those with substance use disorders as well. She'll speak a little bit more about the MGH Bridge Clinic and what services they offer. Both Dawn and Dinah are excellent resources to us, and we're so grateful for their willingness to be here and to speak a little bit more about addiction treatment in the ED and how we can better help our patients as well. So we'll give each of them a chance to speak a little bit, and then as time allows, we can open it up to Q&A at the end. So Dawn, I'll share my screen, and then feel free if I'm off with the timing to just yell at me a little bit to skip ahead.
Thanks, Aaron.
Yeah, of course. Okay, I'll open it up.
So just what Aaron said, we're going to be going through some of the treatment, particularly focused on MGH and the ED, but some of this can also translate to other emergency departments in the system as well. Go ahead. Next slide. So just as a refresher as to what the clinical resources are presently at Mass General, specifically for substance use disorders in the ED. So ED addictions consults right now are 4 days a week, but soon to be 7 days a week starting in August. So we will have providers on service Monday through Friday and also coverage on the weekend. So just a reminder for people at Mass General, please use the addictions consult. It's the ED addictions consult order set for emergency department patients. And that's way we'll get the correct consult. We'll go out to the correct team. If you hit the IP addictions consult order, it's going to go to the inpatient team, and we're not going to see that in the emergency department. That sends off that order. Will be there even in the evening. We'll be able to pick it up first thing in the morning. We're only here during 10-hour shifts during the Monday through Friday. And so 8 to 5 or I'm sorry, 8 to 6 or 7 to 5. And the pager directly is 21987. So please, you can also call me directly if you have any questions or maybe a sidebar that you wanted to discuss about a patient, or shoot me an email as well. So that is really it. There is one advanced practice person in the emergency department, clinician for treatment of substance use disorders. That's the team. So we coordinate definitely with the Bridge Clinic and with the inpatient team as well. So just as a background, why this is so important, this is not news to anyone that's worked in the emergency department or in the addictions world, but the overdose deaths have just grown exponentially during COVID. They had plateaued a little bit beforehand. And now we saw the first drop again post-COVID this past year. However, it's still over 100,000 deaths in the United States every year from overdoses. And often the emergency department are the people that are the only people available providing medical care for individuals with substance use disorders. Some of these patients that we see don't make it to the outpatient setting, or maybe never went to a detox before, or have never engaged with a clinician even around the fact that they have a substance use issue. So we definitely are a critical access point to treatment for patients with substance use disorders. Next. So in the emergency department, that's why it's so important that treatment really needs to start while the patient's in the emergency department. And all emergency departments should really develop evidence-based treatment strategies for dealing with substance use disorders. We need to be able to identify what the patient's particular needs are and initiate treatment. We need to be able to screen and for other psychosocial issues and what pharmacological interventions we can give the patient while in the emergency department. And we need to be able to make referrals to appropriate treatment. And also harm reduction should be provided to patients in the ED. And that all important linkage to appropriate longitudinal services is so important. Next. So unfortunately, even though this is so important, in the past, studies have really shown that emergency department providers across the country are really hesitant to even provide life-saving treatments such as naloxone to patients to go home with after an overdose. So it's incredible that less than 8% of ED patients actually receive a prescription or naloxone in hand after an actual near fatal overdose. And only 8.5% of ED patients receive a prescription for buprenorphine after an overdose as well. So these are definite life-saving measures that should be implemented across the country. There was a poll done at ASAP back in 2017 that really looked at prescribing in the emergency department, and 92% of ED physicians that responded to the poll said they worked in an emergency department without access to medications for addictions treatment. That's pretty a staggering number. I think that was 2007, and 2017, and we've come a long way since, but I still think that we need to move that significantly in the emergency department. Next slide. Another study done in 2020 really looked at providers' actual attitudes and feelings about prescribing medications for opiate use disorder. And many emergency department providers felt that it was not within their scope of practice, that they felt the patient should be deferred or managed by outpatient clinicians, but they did not feel comfortable prescribing buprenorphine, for example, as they felt it was highly diverted and it would actually encourage patients to misuse or sell the medication. So there was a huge reluctance to start prescribing new medication because of fears that it could result in an overdose, or especially around co-ingestion. So that feeling, I think hopefully we're moving the dial so that people aren't as hesitant to prescribing and actually giving prescriptions for patients so that they can maintain on medication when they leave the emergency department. And luckily here at Mass General, we have a lot of things in place that would help with this process. Next slide. Because when we fail to prescribe in the emergency department, it really is a critical opportunity that's been missed. Treatment with either methadone or buprenorphine should be standard practice for treatment of opiate use disorders in the emergency department, because we've had years and years now of evidence and studies that have shown things like methadone will actually, methadone, if it's a patient started and maintained on methadone after an opiate overdose, they have a 53% reduction in mortality at 12 months out. So that's a pretty significant number. I mean, to reduce mortality by greater than half at a year out by maintaining somebody on methadone is one of the reasons we feel strongly that we really need to be engaging patients and prescribing more. Patients were also more likely to be in treatment at 30 days with ED-initiated buprenorphine compared with patients that are just referred out to other treatment methodologies. So it's so important and critical to, like I said, once again, I can't state it enough, to start the patients on medications while in the emergency department. Next slide. So what interventions do we have for opiate use disorder here? So we can start, if a patient's in opiate withdrawal, we definitely want to start them on an agonist, either buprenorphine or methadone, while the patient's in the emergency department, waiting for whatever discharge disposition is going to occur, whether they're going to be admitted or discharged to another facility or discharged with outpatient services. After receiving treatment for acute withdrawal, however, it's really noticeable. Patients are much more receptive to discussing treatment options. So that patient that might have left before completing treatment or might have been a self-directed discharge, if medicated appropriately, very often are much more willing to discuss what the treatment options are and go on for further treatment. It's also important that the medications aren't just started for withdrawal, but the medications are continued during their hospitalization. So we can also start methadone or buprenorphine in the ED and refer the patient on to further treatment. So for methadone, we would set up an outpatient methadone clinic to take them and manage them the next following day. And Dinah's going to talk a little bit about the bridge clinic and methadone as well, as that's an option for us to refer patients to as well. And we can also start buprenorphine and have an induction right in the emergency department and a prescription. Or we also have still the take-home buprenorphine induction kits, which we've had for several years at the emergency department here. And the take-home kit provides for 3 days worth of medication of buprenorphine and instructions for the patient on how to start the buprenorphine when outside of the ED, and then follow up at our bridge clinic. So sad to say, for the first time since we've started this, and I don't know if you remember, Ben, how long it's been. I think it's been at least over 4 years since we started the buprenorphine take-home induction kits. This past month was the first time ever that we did not give out a single kit. So, which is pretty surprising to me, because we've always managed to give out a few kits and referral for follow-up at the bridge clinic. So I don't know if there needs to be more awareness that this is an option for patients, and also to strategize about safer and better tolerated buprenorphine injections so that patients aren't as fearful. And also we can provide comfort meds while the patient's in the emergency department to help during this time of transition when they're going to be started on either methadone or Suboxone as well. Next slide. So those comfort medications are important to start while we're transitioning, because it takes a while to titrate up methadone. It also takes a while to be able to get patients stabilized on buprenorphine. So you might want to make sure you have in place things like clonidine, Motrin, Tylenol, something for somebody's stomach, diarrhea, cramping, etc., nausea, vomiting. And that sometimes, and even something like Ativan can help go a long way in calming the person down so that they can actually tolerate staying and getting started on medication as well. Next slide. So methadone in the ED. So if the patient's already reports that they're on a methadone maintenance program at a clinic, we need to confirm that dose, of course, and then give the dose of methadone while in the ED. And make sure we give them a last dose letter on discharge so that they can go back to their clinic and receive their methadone. If unable to confirm the dose, we can still give a starting dose of methadone in accordance with the way our withdrawal policies set up. So we can give between 30 and 60, depending on how the patient is. You can give that in divided doses if you're really nervous too that the patient might have taken some sedating medication and you're not sure that they've actually been at their methadone clinic recently. And then you make up the difference once the full dose is confirmed. There's often different strategies as well. If we call the clinic and find out that they missed doses, we may need to treat it as a new start and start titrating up altogether, depending on how long they've been gone from that clinic. And then confirm that the patient can go back to their previous clinic. Next slide. So if the patient's in acute withdrawal when they present to the ED and wants to start or needs to get started on methadone, or if we're initiating methadone because they want to get started on methadone maintenance treatment, so we would give between 40 and 60 on day one. And you can, like I said, give it in divided doses if you feel more comfortable. Sometimes there's a lot of unknowns still going on with patients when we're starting up. So they can give it in doses of 20 milligrams at a time or 30 and then follow up with an additional 10. And if admitted to the hospital, that dose can continue to be titrated up during the admission, and our colleagues on the inpatient ACT team would help titrate up that dose to a level that would help really manage cravings for the patient. So the other thing to remember is that when we're starting a patient on methadone, or if they're on methadone maintenance treatment and they come in for an acute pain issue, that methadone is only covering their requirements for treating either opiate withdrawal or cravings for opiates if they've already been on that. So those kind of daily opiate treatment requirements need to be met before any kind of pain control is going to be achieved. So you've got to give the methadone, but then you've still got to medicate for pain. So their pain control needs are going to be higher than other patients related to their tolerance to opioids. Years ago, people would very often withhold pain medications for patients with opiate use disorders because they felt that they were kind of feeding into the addiction. But we know that that's not true now, that actually the person's at a higher risk to either use while in the hospital or leave the hospital and go out and use and overdose if their pain control needs are not met. So we really need to make sure that we continue to treat pain and opiate use disorder as well. When they're on discharge, the patient once again will need that last dose letter to take back to the clinic, stating the time that methadone was given and the dosage as well. Next slide. So the one thing with this, we can't discharge a patient with a prescription for methadone when it's for treatment of opiate use disorders because of the federal regulations. But so we just want to make sure that they are getting connected to an outpatient clinic. That's so important, or to some service like the Bridge Clinic or Faster Paths over at BMC that's going to be able to make that transition for us. So use caution in patients with the prolonged QTC interval, of course, and make sure you check what other medications they're on as well that could be causing that QTC interval to rise as well. The other typical precautions, like any other sedating meds, and dose should be adjusted according to the patient's tolerance. Just a caution though, withdrawal severity is not really well correlated with the patient's own tolerance. So meaning if you give a dose and see how they do in about an hour, 2 hours, and if they're still in withdrawal, start to redose them as well if you're titrating up. Next slide. Buprenorphine in the ED, we usually keep people on the COWS scale to determine the severity of withdrawal. Caution in patients who aren't taking opiates regularly. Maybe they were just incarcerated for a period of time, so the dose may have to start lower rather than higher if they haven't been using for a long period of time and just need to be reinitiated. But for patients that have been using ongoing, it's generally suggested that a COWS score of about 13 when they're in moderate withdrawal. There's a lot of processes evolving around this, and we're going to be changing our own withdrawal protocol as well to make sure that we're able to actually rapidly start people on buprenorphine in a much more timely fashion in the ED, particularly with a lot of concerns about precipitated withdrawal. And consider if the patient can't remain in the ED to start on buprenorphine for that time period, consider then giving them a prescription or the take-home kit. Next slide. That's just a copy of the CAL scale, what people are looking for. Next slide. So acute withdrawal or initiating buprenorphine. So we can actually initiate buprenorphine, and doses in the ED should be around 8 or 16. Higher dosing in the emergency department setting is actually better tolerated. Studies are showing us now, even though we used to start much lower, particularly after an overdose. People can give a really high dose of buprenorphine to somebody and initiate it right away after the patient's received Narcan. So to really get that on board for those receptors. For patients with a decreased tolerance, like I said, they might want to start at 4 milligrams. So buprenorphine peaks at about 60 minutes. But some improvement will be noticeable pretty quickly within 15 or 20 minutes. So if the patient's still not improving in that, in like a 30-minute window, consider redosing, repeating the dose. So maybe to, some studies say even up to 32 milligrams in day 1, but others will say about 24 milligrams. Observe them in the ED for excessive sedation or withdrawal. And once again, home induction is still an option for patients. And we're talking about Brixadi, which is the weekly dosing. We don't have it yet in the emergency department, to my knowledge, but we're going to be starting on a process to hopefully get patients started on the 7-day buprenorphine, which would be a game changer for people and really save a lot of lives, I feel. Next slide. This is just, and you can feel free, Erin, to share these slides with people if they want it. This is just an example from one of the studies on high dosing buprenorphine, like I said, up to 32 milligrams in the first day, and how well tolerated it actually was. Next slide. Precipitated withdrawal, there's a lot of talk about precipitated withdrawal. So because buprenorphine has a higher affinity for the mu opioid receptor, so it can displace opiates without really still activating that receptor to the equivalent degree of the prior opiate. So the patient will go into withdrawal. There's actually, studies are now coming out that say that concerns over precipitated withdrawal with fentanyl are actually over-sedated, and that in observational studies in the emergency department, precipitated withdrawal was seen less than 1% of the time of all people initiated on buprenorphine. The thing with precipitated withdrawal, actually the best thing to do is keep treating it with more buprenorphine. So you can really start loading the dose of buprenorphine if the patient does go into precipitated withdrawal. And utilizing augmentation strategies such as Ativan goes a long way, I found, for anxiety for patients if they're not sedated, for really helping to get that Suboxone loaded and on board. Next slide. This is just the order set for the take-home Suboxone. It's so easy to do. You don't even have to know the dosing. You just hit the button, order the kit, and then the pharmacist pulls it out and gives it to the patient with the teaching, or the clinician can do the teaching, but the pharmacist will label it and pull it. So easy peasy, don't even have to know doses, just take home Suboxone. Next slide. This is just an example of what the teaching goes with the kit to tell patients how to start on Suboxone safely. And then the patient should also have a referral place for the bridge clinic, and at the same time order a naloxone take-home kit as well for the patient. Next slide. Naloxone, can't say it enough. Please make sure your patients leave with naloxone. So we do have it here where the kit can be delivered to the bed. All the pharmacies in Massachusetts, including our Mass General Pharmacy, can provide it as well. without a prescription, but I say order it and give it to them at the bedside or their family members while they're here, because it is an opportunity to save a life. A lot of times patients will say to me, I'm all set, I don't need it. And I'll say, but you could save somebody else's life out there on the street, so take it. So I give it to all patients, even with substance use disorder. Next slide. I'm not going to get into amphetamines and cocaine today. We don't have nearly enough time other than to say, please, give patients benzodiazepines, try to get them calm and under control so that we can make treatment referrals. And after benzodiazepines have been initiated, something like neuroleptics like Haldol or Zyprexa can be helpful as well to help with the psychosis and agitation. But we'll get into that some other time. Next slide. Harm reduction. So harm reduction is a spectrum, right? It's a spectrum of practical strategies of things we can actually do to help reduce harm, and that patients can actually do as well, and reduce the negative consequences associated with drug use. Harm reduction is also a social justice movement. It's really built on that founding principles of respect for all people and the rights of all people, including people who use substances. It's about meeting the patient where they are, presenting them with options and alternatives to risks, so that they can help maybe modify their own behavior to reduce risk to themselves and to their community. So the goal of providing a harm reduction kit in the emergency department is really to help people stay as healthy as possible and adopt practices to reduce the risk associated with substance use. Next slide. So we do have ED harm reduction kits. They contain a pamphlet on safe injection education. They also have resources in there as well to connect the patient with. They have sterile syringes, sterile mixing solutions, alcohol prep pads, cotton balls, containers for dissolving their substances in, bandages, tourniquets, twist ties, and condoms. We also have a smart phrase that can be used to help document in your notes that you've reviewed kind of harm reduction as the best means of minimizing any complications of intravenous drug use and preventing the transmission of infectious bloodborne pathogens. So it's helpful. There is an order in Epic for harm reduction kit. If you place that way, that helps us track how many kits are given out and just the par level. A nurse or a clinician can get the kit. It's stored in the evaluation med room in the cabinets underneath the countertop, marked harm reduction kit on the outside of the cabinet. So anybody can get that out. So the clinician can dispense the harm reduction kit directly to the patient at time of discharge. Next slide. So harm reduction is also, the attempt is also to engage patient in care as well. So anything else we can do, such as does the patient want screening or testing for STIs, HIV, hepatitis? Once again, those harm reduction kits. Also, facilitating engagement in does the patient require PrEP or PEP is something we can provide right in the emergency department. Facilitate ongoing care to outpatient clinics such as our own Bridge Clinic or other SUDS clinics, or the sexual health clinic or the infectious disease clinic are helpful. We also have recovery coaches to engage and with the patients, and peer navigators as well from ID will also come down and help. We have fentanyl test strips in that same cabinet as well that are available to hand out to patients as well. And something like xylazine wound care, going over how to care for wounds or how to dress those wounds that patients occur, is also a helpful way to engage patients. So there's always something we can do, even if the patient, for far too long, it was always that for substance use, every road is a detox, and that's not the case. There's many other things we can offer to patients in the emergency department. Next slide. So referrals, we can make referrals. There's all kinds of, whether it's an outpatient setting, whether it's methadone, whether it's a detox, whether it's medication about counseling. low barrier treatment, intensive outpatient programs. But there's plenty of places to refer people to. I don't know. Next slide. This is just a slide on the Bridge Clinic, and Dinah's going to go into that, so I won't cover it, but go ahead. One of our main referral sources. The other thing I wanted to point out to people is this resource. If you're completely baffled and lost on what to do, there is a website or a phone number up there, at 1-800 number, and it actually is a state-run website that you can put in what the patient's looking for, or the patient's family can do this at home as well. What insurance they have, so whether it's a detox, what area, how far from Boston, et cetera, and it'll give you an actual list with phone numbers of what programs there are so that people can call. You could put in something like methadone clinic and it'll pop up what clinics are in the area as well. Next slide. So really it's about treating patients where they're at, but not leaving them there, right? Trying to initiate some other kind of treatment and linkage. There is the ED addictions consult order and pager that's available to you. Engagement with peer specialists is super helpful. Harm reduction, starting patients on medications, just knowing some referrals. And with that, I'm going to turn it over to Dinah.
Awesome. That was so great, Dawn. Can everybody hear me okay? Sorry, I was responding to a page. So I'm just closing out my Epic and then I'll share my screen. I have some slides, but I really hope that we can have time for a discussion. But I was asked to provide some slides. So let me.
Can we ask Dawn a question while you're doing that?
Please.
Hey, Dawn, it's Leslie.
Hi, Leslie. Oh my God.
Thank you so much for all you do and what you've created there with a very small staff. I know you have help from Wendy and Ben, but it's really amazing what you've come up with with a limited resources. I did have a question about the methadone clinic. I know it's been difficult to get people into a methadone clinic. Will Bridge Clinic manage them until they get into one? Or what is the actual process?
Yeah, so our goal is to try, we have a few connections with a few different methadone clinics that are better at picking up the phone and getting our patients referred directly. So they would honor, like if we gave methadone in the ED today and say the patient had 40 of methadone and we give them a last dose letter, they would honor that dosing for the next day, but it is always a battle. So with that, the Bridge Clinic has really taken on a lot of the heavy lifting recently. And Dinah's going to talk more about that, I think, with what's going on in the Bridge Clinic now with methadone and what's soon to come as well. So she'll go through that.
Yes. Okay, let me share. Sorry, it shared and then I unshared because then you can't see faces, and now I'll reshare again. So again, I'm Dinah, she, her. I'm the medical director of the Bridge Clinic. I also do primary care and also some care at healthcare for the homeless. So let me. All right. So just a reminder that, as was mentioned, MGB has a lot of different Bridge clinics. So I'm going to specifically be talking about MGH, but there's a Brigham Bridge Clinic, there's a Salem Bridge Clinic, and really the aim for all of our Bridge Clinic is to offer compassionate, non-judgmental, immediate access care for people with substance use disorders. The Bridge Clinic model for all Bridge Clinics is really to support people in to reach whatever goals they give us. And we really let patients define their own, what recovery looks like for them. So for some people, it may be abstinence. For some people, it may be safer use, moderated use. And really, care at all Bridge Clinics is on demand. So the idea is that people can walk in, get care when they need it. And we are all Bridge Clinics. So we're bridging people to long-term care. So as patients stabilize, we help connect people. We actually have someone whose role it is at our Bridge Clinic to help connect people to long-term care. Of course, we have some patients who are with us forever. They will always kind of need a really low threshold, harm reduction oriented, flexible model of care, and that's okay too. But most of our patients actually are able to ultimately transition to long-term care. We are located on Cox 1, and our hours are 9 to 5, Monday through Friday. And as Dawn mentioned, there's some changes coming to, in the same way there's changes coming to the ED, and there's going to be more staffing in the ED. We also have some more staffing coming to our MGH Bridge Clinic, actually to all the Bridge clinics. What that means at MGH is that we're going to be expanding to be open till 6, and we're also going to have limited hours in the morning to early afternoon on Saturday and Sunday. Our team is really nursing led. Our nurses run the show. They kind of are triaging everybody in the waiting room, who's being seen by what. We providers really just do what the nurses tell us. They lead the way. We also have physicians, and we're generally family medicine and internal medicine. We have nurse practitioners, medical assistant, recovery coach, resource specialist, which I mentioned is she really focuses on both 72-hour methadone, but also connecting people to long-term care. We have a virtual consulting psychiatrist who's doing some limited psychiatry, but we will have a psychiatrist with more in-person care coming to us part-time in the fall. And then we have therapy and a social work position that's currently vacant. So we have a huge staff, but on the typical day, it's a little bit more limited. So we almost always have a nurse, one provider, and one resource specialist Monday through Thursday, and then 1 or 2 front desk staff persons. And then we have an in-person recovery coach approximately half the time. And I was going to show you this video that I love that that features 2 of our recovery coaches. Actually, it features a lot of the MGB recovery coaches, but 2 MGH recovery coaches. But for the sake of time, I won't. But I do encourage you all to watch it if we send out the slides. They really are essential non-clinical members of the Bridge Clinic team and a huge asset to what we're able to offer patients. So a recovery coach is a person who that themselves identifies as being in recovery, and so they have a shared lived experience with a person who's trying to access care. All right, so who to consider for a Bridge Clinic referral? It's pretty much anybody with a substance use disorder who may be interested in something that we could offer. So we offer outpatient treatment. So that's going to include pharmacotherapy, psychosocial treatment. I put here just to remind myself to mention to you guys, 72-hour methadone is a new thing we're offering, which I have a separate slide on. Ambulatory alcohol withdrawal management, we do offer, and I have a separate slide on. And then I just typed in to remind myself, as Dawn was talking, Brixadi. So we now have Brixadi, which is another injectable buprenorphine formulation. So it's like Sublocade, but it's actually preferred to Sublocade for some reasons, including it's a weekly and monthly formulation. There's way more dosing options. You can use the weekly formulation in pregnancy. Doesn't need to be refrigerated. It's a smaller, less painful injection. So we're really excited, and we now do have it available. We're still kind of sorting through the prior authorizations. Most insurances are requiring a prior authorization, so we are defaulting still to Sublocade, but Brixadi, as Dawn mentioned, is really exciting because it actually has a lower kind of rise. Its pharmacokinetic profile, it really lends itself to actually helping people with bupe inductions, so that in emergency departments across the country, there have been studies. There's a study that's ongoing that shows that people, if they come in with a COWS of just 4, which isn't huge, get the weekly Brixadi, kind of the middle weekly Brixadi dose, they do well with very, very low rates of precipitated withdrawal. So we're just trying this as a buprenorphine injection strategy at Bridge Clinic. Harm reduction services, so similar to the ED, we have safer injection kits and supplies. We also do PrEP and PEP. We do infectious disease screening. Sometimes we treat hepatitis C. But we do not, there was a time where we were actually getting a lot of referrals just for primary hep C treatment, and we really don't have the capacity to do primary hep C treatment. We really are treating hepatitis C in patients who are otherwise engaging around or interested in substance use disorder care. And then we also help with referrals to higher level care. So whether that's an intensive outpatient program, whether that's residential treatment, a methadone clinic, we do not have a daily case manager or a social worker. So generally, who the person who does this really ranges. Sometimes the provider will do it a little, the nurse will do it, the MA will do it, the resource specialist, recovery coach. So we all try to help patients as much as possible. But we don't have somebody whose only job is this. And if we don't find a program, patients will be directed to just return to us the next day. And so that's important to note. So for patients with alcohol withdrawal who really need an inpatient level of care, they really should be remaining in the emergency department for placement. All right, so the workflow. So there is an ambulatory referral in Epic to the Bridge Clinic. What that referral does is prompts the front desk team to reach out to the patient. Patients do not need a referral to come to the Bridge Clinic. We are walk-in, so it really is just a way for us to track referrals, and it does prompt an outreach. But really, if a patient is interested in coming to Bridge Clinic, like, encourage them to come that day, right? We love patients to come over same day. It's great if a member of the staff can walk the patient to Bridge Clinic, or they can just walk to Cox One and check in at the front desk as a walk-in. And please, if you have someone who you're really worried about, if you want to do a warm handoff, you want to see if one of us can come and take the patient over to us, please always feel free to page the Bridge pager. We're in the directory. If a patient doesn't want a same-day intake, that's fine. You can let them know that they'll be called by the Bridge Clinic to schedule an appointment, but also let them know that they can also always walk in. The earlier in the day someone walks in, the more likely it is that they'll be able to get a full provider intake that day. As Dawn said, so all patients with opioid use disorder, even if you're referring them to us, we recommend you offer them a bube kit, and if interested, give them a dose in the ED if it's clinically appropriate, and that all patients with opioid use disorder are at risk for overdose get naloxone prior to discharge. And that's just because there are patients who say that, a lot of patients say they're heading over to Bridge and then they don't make it to us. So we'd rather at least you all have given a bube kit and given naloxone in case they don't make it to us. Or sometimes patients kind of take a long cut on their way, maybe go out for a cigarette break and they don't come in until 10 minutes to closing. And so it's really good if we can at least make sure those minimum safety measures, including a safer injection kit, have been given. All right, a note for alcohol withdrawal management. And I'm presenting to you guys what we had kind of put together as an ideal workflow. But obviously this is the ideal. But it's not what always happens, and that's okay too. We're a team. But the goal is that if you have someone who you think may be appropriate for outpatient withdrawal management, which I'll talk about on the next slide, you can refer them to Bridge. Please make sure that there is a CWA documented. And then in addition to placing the Bridge referral, you page the Bridge patient, the Bridge Clinic pager, ideally with the patient information, and wait for a call from us before sending them over. And the preference would be for you all to administer at least one dose of a long-acting benzo like Librium or Valium. This is a different process for when Dawn or the ED Act provider is available. We kind of coordinate separately. They're really able to know whether we're going to be able to manage them in Bridge or not. But for ED providers, this would be the ideal. And the reason for people who you're referring for outpatient alcohol withdrawal management, the reason that we really, in the ideal situation, request a page is that we really are between a level 1 and a level 2 for withdrawal management. And so the patients that we can handle, it's not very easily protocolized. So there's not necessarily a specific CWA cutoff. We will sometimes manage people who have had an alcohol withdrawal seizure, who have severe withdrawal. We do have an Omnicell and can administer meds, but really the level of monitoring we can do is based on both patient volume and the staffing. So there are days where we're much more like operating like a level 1, where we really are a little more conservative in who we can take and see, and other days where we actually can manage pretty at-risk patients. And depending if it's late in the day, we also can't always guarantee the availability of a provider for an intake. So again, please, if you ever have questions about whether someone's appropriate for a Bridge referral or whether they need to stay in the ED, just give us a page. We all share the goal of getting patients out of the emergency department and to Bridge Clinic. I think it's a better place for patients to be when they're looking for placement, for alcohol withdrawal. And so we want to help you bring patients safely over to us, but you all can't always know kind of what our availability is in Bridge is like. So we want everybody to be really comfortable paging us. And now for methadone. So as everyone knows, you can't prescribe methadone for opioid use disorder unless you're a methadone clinic. You can only prescribe methadone for pain otherwise. But there is something called the 72-hour rule, which allows the use of Schedule II medications for emergency opioid withdrawal management. And so it's an exception to the rule that only OTPs can prescribe methadone. And basically the workaround is that you can dispense, you can't prescribe it. So you have to be able to dispense the methadone. So we dispense it at our own from our Omnicell. And you can do it only for up to 3 days as you work to either initiate maintenance treatment or detox treatment. And actually, this rule that people often call 72-hour methadone rule applies to any Schedule II medication. So in Bridge, we use this to both administer and dispense methadone and morphine. We use morphine in various ways that if we have time, I'm happy to talk about. But generally, we use this to both start and connect people to a methadone clinic, to treat withdrawal prior to a hospital or ED presentation, to assist with bupe induction, so to give people a full agonist as you're doing a low-dose bupe induction, or to prescribe a full agonist to allow for a fentanyl washout. And we can also do missed methadone doses. So you are absolutely free to let patients know. Faster Pass was really the leader in this at BMC. And so you're welcome to let patients know that we offer this. And right now we are only starting it on Monday, Tuesday, and Wednesday. And that's because we're not open on the weekends right now. We will in the fall be open on the weekends. And so we really need that full 3 days to help connect people. And so intakes are Monday, Tuesday, Wednesday, but we'll do missed dosing 5 days a week. And then we're dosing people 5 days a week, because for people who start on a Wednesday, we then dose them Wednesday, Thursday, Friday. And we do direct admissions to the methadone clinic. So that means that the methadone clinic accepts our note, our admission as their intake, which means that they are kind of able to be at that higher dose for longer. So we try to get people's dose up to at least 60 or 70 milligrams prior to their referral to a methadone clinic. Otherwise, sometimes people are waiting and kind of staying at a 40 milligram dose for a couple weeks until the provider can do their intake and allow for their dose escalation. People get kind of, if somebody comes and doses with us and doesn't connect, they're allowed to try it again. We need a week between trying. So if they don't make the connection, we'll try it again after at least 7 days. And if we've done this 2 times and they haven't connected, then we generally don't do it again. And this is just based on the lawyer's kind of interpretation of the law. It's a little bit arbitrary. I'm happy to answer more questions about that if there's time. Those are all the slides I have. Let me stop sharing.
That was excellent. Thank you both so much.
Yeah.
We have about 10 minutes or so we can open it now to Q&A if anyone has any questions for Don or Dinah.
Hi, Dawn and Dinah. It's Wendy.
Hi,
How are
Wendy.
you guys, long time no see. Thank you for presenting on this. I have a quick question. I heard it said that, now that we can actually, start people or offer people methadone, the last dose letter may become more and more necessary if that practice picks up in the emergency department. Do we have a smart phrase, or would it be possible? It seems like a low-hanging fruit to just create a smart phrase for the last dose letter if there isn't one, just to reduce that barrier to prescribing.
That's a great suggestion, Wendy. Do you use one, Dinah? I just have the same. I have like one that I just read.
Yeah, we have a dot phrase that you can pull that language. I wouldn't use our exact dot phrase. We decided for our workflow to make the dot phrase my signature on all of our bridge dot phrases. But yeah, you could certainly create one for the ED, for all ED providers to use, that then inserts the, I guess, prescribing whoever provider's signature into that.
Okay, great. Thank you. And maybe Dawn, we can work offline.
Yes, that'd be great.
I'll ask a question. So I'm so excited to hear that you guys are bridging, or like having more resources to be able to provide these services on the weekends. I was wondering what some of the barriers have been just for my own education to this in the past, and especially like having like a 24/7 provider.
In the ED or in bridge? Well, I guess for both it's funding. So there was a time where we had funding for the weekends, like what, 6 years ago, and then it was taken away. It is funding. So I think in the ideal world, we would all think that, like, yes, there should be a dawn and a full-time like social worker who's helping with placement, right? At Bridge, we would have someone. So it's all of it really is funding. And so this most recent expansion is being allowed by a grant from BSAS, and it's a 5-year grant with an opportunity for extension. So we're hoping that this will be extended and that we'll be able to then maintain the expansion. But funding has always been the issue. Yeah, we were able to staff up because we'll be expanding to weekends in February, and or in the fall, and tons of interest. So people are interested in staffing these sessions. Just need the funding.
What is the recommendation when someone comes in over the weekend to the ED in terms of resources, follow-up, without much help there on the weekends for the problem?
So starting in August, at least, there will be coverage during the day for partial in the emergency department. And then, as Dinah said, the Bridge Clinic's going to be expanding as well in the fall. But in August, you will have some help. The big goal is to get people at least semi-comfortable. If the person could at least get started on methadone, no matter what time of the day it is, or started on, say, buprenorphine, or given a take-home kit, or that's something that could be done at any time of the day. And then the patient could have a follow-up, say, at the Bridge Clinic, to get all the other pieces together. And they're much more likely to make that follow-up if we provide medications for them while in the ED.
Yeah, but that's why, I mean, it's been a huge problem, right? Like, oh, people only come in for addiction when Dawn's working, right? Tuesdays and weekends, like, so we are really, really hopeful that the ED providers and patients will really feel the difference by having Bridge available 9 to 12:30 on Saturday, Sunday. That will be in the fall, and then having an ED, having an ACT provider when Dawn isn't there on, right? It's Tuesdays that you're not there, right, Dawn? Yeah, on Tuesdays, and then on the weekends. So you guys will have more support 7 days a week. Right. Thank you guys for coming and for letting us chat and for asking good questions. And please always feel free to also email me. It's d.applewhite@mgb if you all have any questions or ever have any difficulties connecting to Bridge and want to kind of, we're working out workflows, especially as we expand, and we want to make sure that we're accessible and that it feels easy to connect patients. And sometimes that doesn't always happen. So please, low threshold to reach out, email me so we can make sure our patients are getting the care they need.
Thank you both
John.
so much.
Yeah.
We really appreciate both your help every day at MGH and for, coming to speak with us. We will be, we recorded this, so we'll be posting it. We're working on making like a YouTube page for our morning report team, so
Cool.
we can reach a broader audience.
Awesome.
Get this out there. Thank you.
All right.
Thank you both.
Bye.
And Dinah, I just wanted to give you a little bit of props too, because the harm reduction kits in the emergency department are really they were made possible by you, and you were so instrumental in helping us to organize that. So thank you very much. And I'm hoping that harm reduction kits are more and more dispensed.
Yeah, no, that was such a good team effort, Wendy, Dawn, it took a long, long time, but it finally happened. And I'm actually working on an MGB protocol to kind of say, yes, this is something we should be doing at all of our sites. And so hopefully we'll be expanding more across MGB.
That's wonderful. Thank you so much. Good to
right.
see you. Bye-bye.
Bye, Wendy. Good seeing you. Bye, Dawn.
Bye.
Bye.